Oh. Okay, I believe that's it. And let me see if I am able to share it with you.
If you want to email it to me too, I can.
Hello, everyone. Participants have started to join. Just wanted to flag.
Okay.
There you go.
Can you see the presentation?
Yep. So I have a few slides to get started.
Okay.
So you'll have
I
to
stop sharing?
You stop sharing and I will share.
Okay. Sounds good. Sound is okay?
Perfect.
Can you hear me okay?
Perfect.
Okay, good.
All right. I think we have, good morning, everyone. I think we have a pretty good group of people to start the conversation. Brandon Garrett with the National Minority Quality Forum, first webinar of 2023. So welcome back, and hopes everybody's having a good new year so far, which is usually the longest month, seems to be the longest month, January. We're gonna try to make it a little shorter by providing you some entertaining information on vaccine, racial, and ethnic disparities. But before I do that and turn it over to our own Dr. Laura Lee Hall, so to make two big announcements or plugs. One, we have our National Annual Summit on Health Disparities. That registration link should be coming up soon. It's April 17th and 18th in Washington, DC. And then as part of it, as many of you know, we have an application for the 40 under 40, those top 40 under 40 minority leaders in minority health. I will go ahead and post a link in the chat about the application, which is due the second week of February. And so without further ado, I'm going to turn it over to Dr. Hall.
Hi, everybody. Happy New Year. We're almost too late to say that with January coming to a close. I appreciate you, Brandon, introducing this session, and Adjoa for you and your team's support. It's really my distinct honor and privilege and joy to introduce the amazing Dr. Mahmud, who I've had the pleasure of knowing and working with for a number of years now. So I'm going to just give a couple little thoughts. So I'm not going to read this aloud. I think you can see that Dr. Mahmud is one super accomplished individual who has done some amazing work, but he's also got a giant heart and cares about people, including people of color and equity. I just took this from the CDC's website to make the point that we seem to continue to have disparities in flu vaccination. So far for this season, so this is mid-January, you see that the coverage among Black non-Hispanic children was under 40%, 10% lower than among white children. Interestingly, Hispanic children were more like white children in terms of their flu vaccine rates. Flu vaccination coverage for pregnant persons is 43% overall, but lowest among Black non-Hispanic pregnant persons at 25%. And we see those disparities continuing among adults. That's everyone over 18. Among white adults, 45%, among Black adults, 33%, and Hispanic adults, 28%. These are data from mid-January on the COVID vaccine. And I don't want to go through all of this except to point out, let's take a look at the bivalent booster dose. So Among Black populations, it's only 8.4%, 7.9% among Hispanic Latino persons, and really double that among white individuals. I guess I started working with Dr. Mahmud when we did this first paper, which really was just a mapping of Medicare fee-for-service individuals in terms of flu vaccine uptake. And I will only point out that this study, not as elegant as Dr. Mahmoud's further work, but you see that the Black population has a much lower rate than the white population, as is true for the Hispanic population. And the map here shows that you're not really talking about, one even color across the whole country. The rates vary at the zip code level. And in fact, that has led us to continue doing our work to promote vaccination equity in areas where most need is. This was a second study that we had the benefit of partnering with Dr. Mahmud, and it's simply, and he'll explain this much better than I, but in essence, for folks who were vaccinated, so we're not talking about individuals who did not get a vaccine being included, but among vaccinated individuals, many fewer Black Medicare fee-for-service beneficiaries received the high-dose vaccine, which is much more effective among that age group. So I'm going to say thank you, everyone, for participating today. Thank you so much, Dr. Mahmud. Put your questions in the Q&A box if you don't mind, and we will look forward to you providing really good information and questions for Dr. Mahmud as we get to the end of our presentation. So let me unshare. It's all yours. You're on mute, Salah.
Thank you. I'm actually in double mute. But can you hear me right now?
Clear as a bell.
Excellent. Thank you. So thank you so much, Laura Lee, Brandon, and your team for the kind invitation and the really generous introduction. Thank you so much. And happy 2023, everyone. I hope this year is the end of or the beginning of the end of the disaster that this decade is shaping up to be. So when I talked to Laura Lee about this presentation, and after she sent me an email that starts with hot dogs and ended with hot dogs, an expression that I had no idea what it meant, but now I know. Thanks, Laura Lee. She also sent me a nice email that literally that's what it says, in the email. I just copied it into the screen here, asking me to talk about racial and ethnic disparity in flu vaccine uptake, trying to answer these three important questions. Do they exist? Why they exist, and what needs to be done? And that's exactly what I'll try and do very briefly, if I can. And so the answer to the first question, yes, they exist. And we know that because we did a systematic review. We looked at the published papers in the literature in the last 20 years. And we found about 4 papers, and we summarized the evidence here. And as you could see, the evidence is consistent that for Hispanics and African Americans, they are about 40% less likely to get the influenza vaccine compared to whites. The evidence for the Asian communities is not as consistent. So why? So the dominant discourse at the time when we started working with Laura Lee and Gary and the Sanofi team led by Ayman Sheet, the dominant discourse at the time was that this could be either due to lack of health insurance, low health literacy. People they don't know what they should be getting, and they don't argue with their physicians effectively to get the vaccines that they need, or vaccine hesitancy. People know and distrust of the healthcare system and sometimes society in general. And underneath all of that is lower income and less education, which is driving all these factors. And we thought these are all reasonable, causes or drivers for lower uptake of vaccines, but we thought there could be, or there should be something else, because if you look at things, for example, like lack of health insurance, countries in like Canada and the UK, it's well documented that minorities there are less likely to get the influenza vaccine as well, despite the fact that these countries have very generous insurance systems that universally cover the entire population and preventative services, including influenza vaccine. So we think there must be something else. The problem is, how do you address this? How do you try and understand the other factors that might be leading to the gap in vaccine uptake? It's a vexing problem. I mean, there are lots of problems technically, in terms of trying to measure vaccine uptake. But luckily for us, Sanofi around the same time came with a new product, the HighDose vaccine, influenza vaccine. It has 4 times the dose of the product as the standard vaccine that was used at the time, and it was shown to be more effective. About 24% more effective than the standard influenza vaccine among people older than 65 years. And so it was gaining market share quickly, but there was no preferential recommendation for the vaccine. It was left to physicians and healthcare providers to decide which product to give. So this created a natural experiment for us to be able to assess the issue of whether the gap in vaccine uptake is all due to lack of insurance and vaccine hesitancy. So our hypothesis was that minorities will get less of the HighDose vaccine, and if that's the case, that will support the theory that the gap has nothing to do, or at least is not all about lack of insurance and vaccine hesitancy among minorities. So at the time, a group of people came together from the NMQF and Sanofi, the Vaccine and Drug Evaluation Center here in Canada, and a few other colleagues. And we started a number of studies. The first one of them, it was a national cohort that included more than 26 million Medicare beneficiaries. They were all Plan A and B beneficiaries, and they were all above the age of 65 or older. The data was only for one flu season, 2015 and the 2015-16 flu season. So the first thing that came out of that is what Laura Lee has already shown you a bit of it, which is the mapping of the inequities. And that confirmed the fact that what we saw in the literature from the previous 20 years, that there are still significant gaps. And you could see that clearly, for example, here, if you look at this is a New York City map, and the yellow color indicates low vaccine uptake, and the darker the color, the higher the vaccine uptake levels in that area of the city. And you could see that there is a significant overlap between the areas of low vaccine uptake, influenza vaccine uptake, and the areas where minorities reside. And we saw the same thing also for the high dose vaccine. So we became, more confident that using the high dose vaccine was going to be, a reliable way to look at vaccine hesitancy, vaccine inequities in general. The second paper looked at the issue of flu vaccine uptake in more detail. So as you could see here, we found that if you just look at any influenza vaccine, all minorities except Asians were less likely to get the influenza vaccine compared to whites. And regardless of where they lived in the country, you could see here we divided the country into 5 zones, and there are differences between the different zones. And we have another study that's looking at this into more detail, regional differences in vaccine uptake. But regardless of where you lived in the country, it seemed like Blacks and Hispanics are less likely to get vaccinated. Asians were doing better than whites, and that was, similar to what we've seen in the literature at that point. The other two lines here, the LIS means low income subsidies. And so we divided the population into people who received subsidies and people who did not. And as you can see, when people receive subsidies, the gaps are smaller, but they're still there. So this is for the uptake of any flu vaccine. So looking at this, we confirmed what we have seen in the literature, as I said. Now, looking at the high dose vaccine, the picture changes a bit, but it's still consistent with the theory that the high dose vaccine is a marker. The uptake of the high dose vaccine is a marker of the uptake of the influenza vaccine. You could see that now Asians are not doing as well. Remember, with the Asians are the green bars here. With the uptake of any vaccine, they were doing much better than whites. When you get into the uptake of the high dose vaccine, the vaccine that was perceived to be a better vaccine, they're not doing as well. It's actually only in the South where their uptake is higher than the uptake of whites. Everywhere else, and the Midwest, sorry, to some extent, but everywhere else in the country, even Asians were doing poorly. So when it came to the high dose vaccine uptake, minorities in general were doing poorly. And as you can see, income subsidies as well here played a bit of a role. They reduced the gap by about 10 or 15%, but the gap persisted even when people were receiving subsidies. Now, in general, what came out of that study is that compared to whites, Blacks and Hispanics were about 20 to 40% less likely to receive any flu vaccine, high dose or otherwise. And when vaccinated, all minority groups were less likely to receive the high dose vaccine, although with some variability between regions. The other thing that we did was to try and see if this could be explained by differences between ethnicities in terms of education, income, and health status, things like chronic disease, immune compromise, and things like that. And what we found is that the gaps persisted even when we adjusted for all these variables. So we thought that there must be something else. Now remember that when you look at the high dose group, that everyone in that group is vaccinated, right? When we look at the high dose as a marker, the entire group has received some vaccine. We're just looking at whether people received the high dose or not. And so vaccine hesitancy is not an issue. People received the flu vaccine, so they're not vaccine hesitant. And as I said, because this is a study that included all Plan A and Plan B beneficiaries, everybody was insured. So the fact that we still had these gaps in vaccine uptake, in the high dose vaccine uptake, suggests that the reasons, the drivers for the inequities go beyond just vaccine hesitancy or lack of insurance. Now, what we did not know at the time is a number of things. Number one, I remember one of the reviewers saying, well, this is just 1 year. It's possible that this was a bad year. And if you look at more recent data or more data, things might change, which we thought was a reasonable suggestion, although we knew that these gaps have persisted over 20 years. So we had no reason to think that they would change, but the high dose vaccine was being used more frequently, and we thought maybe with more frequent use of the vaccine in the country, things might have changed. The other thing people said, well, this is Plan A and Plan B Medicare groups. Maybe if you look at Plan C, the Medicare Advantage group, which I think, I don't understand the US healthcare system well, but from what I hear, they supposedly they are better plans because people pay into them. So maybe if we looked at the MA, the Medicare Advantage groups, maybe things would be different. And the other thing, we did not have information about the providers of the vaccines or about the characteristics of the different communities. So we were able to look at personal factors, some socioeconomic markers and healthcare status and things like that as possible explanations for the differences. But we were not able to look at things like, the gender or the age of the vaccine provider or where they practice, things like that. That information was not available to us. So luckily, Sanofi supported another study where we used data from the Optum database, which includes about 60 million people across the country, I think. We were able to look at Plan C because they provide that kind of insurance, which is not included in the Medicare data, the CMS data. And we were able to look at more seasons. So I think this study kind of provides a deeper understanding of what's going on in the country using more recent data. So what we did is we looked at about 3 million different vaccinations. And as I said, everyone was a Plan C beneficiary, and everyone again was 65 plus. And we covered the flu seasons from 2014 to 18. The other thing that because this was a much richer data set, because the insurance company was collecting a lot more detailed information, both at the individual and the community level. So we were able to explore the different kind of providers, the drivers of the of inequity, which we summarize in this chart here. But essentially, they include personal factors, community level factors like insurance, percentage insured people, availability of doctors, things like that, and also provider characteristics. So we use this diagram here to kind of guide our analysis. And I'm sorry to unleash this dense table on you, but it kind of summarizes the message from this paper very nicely. And I will take you kind of slowly through it. What the first thing that we found, now that we know where people are vaccinated, is that there was a big difference in the size of the gap between people who were vaccinated in physician offices and people who were vaccinated in pharmacies and outpatient departments and things like that, other types of medical facilities. Mostly pharmacies, though, that was the majority of these vaccinations were done in pharmacies. So we found a big difference between these two groups. So that's why you could see here in this table, we're presenting the data for the physician, those who are vaccinated in the physician offices separately from those who were vaccinated in pharmacies. The other thing that we found is that there was a big difference by county. And the most important factor was the percentage of the population that was a minority using census data. And so when you see here a minority county, that means that 20% or higher proportion of the population are minorities. Non-minority counties are the counties that had less than 20% of their populations as minorities. So 20% was used because it was the median of the distribution of the percentage of minorities in these counties across the US. So essentially, this looks like a grid now and makes things a little bit more complicated, but I think it gets into the essence of the issue at a better kind of level. If you look at the first row that's labeled baseline, that shows us what percentage of, you could interpret this as the percentage of Blacks or Hispanics, Asians, minorities. By the way, we looked at the minorities separately in different analysis, and the pattern was the same, the trends were the same, so we decided to group them together, just because otherwise things would have been even more complicated. So if you look at people who were vaccinated in a physician office and they live in a minority county, essentially there is a gap of about 38% between minorities and whites in terms of the receipt of the high-dose vaccine. So people who were vaccinated in physician offices living in minority counties were 38% less likely to get the high-dose vaccine compared to whites. And you could see that's the biggest gap. So how do you arrive at that? Just subtract this number here in the cell from 1. So 1 minus 0.62, that will give you a 38% gap, essentially. And immediately you could see in the next cell that minorities who were also vaccinated in physician offices, but they happened to live in a non-minority county, they were doing slightly better. The gap was only 23%. So this is the first observation, that there is a disadvantage for minorities living in a minority county. There is a penalty of, I don't know, about 10, 11%. Now, In a different analysis that I'm not showing here, we found that even whites who live in non-minority counties, they have a lower uptake of the high-dose vaccine compared to whites who live in non-minority counties. So living in a minority county by itself adds to the size of the gap. The other thing that you could see from the table here, that there is a sequential adjustment. That's what the plus sign means. And the idea here is that as we add more variables, we're kind of explaining the gap. So the gap gets smaller. And if you look at the most important changes in this first two columns for the physician office vaccinees, socioeconomic characteristics, they explain maybe about 30% of the gap, because the gap goes down from 38% to about 27%. Once we add to the model factors like education and income and receipt of subsidies and things like that. So definitely education, income plays a role in the size of the gap. So minorities who have higher income, higher education, they're doing better than other minorities, but there is still a gap of about 27%. Now, as we add other factors like your medical history, whether you're immune compromised, you have dementia, you have heart disease, etc., your measures of healthcare utilization, how often you go to see your doctor and get admitted to a hospital, get prescriptions. Community characteristics, which we looked at more than 100 different variables, but things like the rate of physicians in a community, how prevalent doctors, how available doctors in your county, the percentage of people who are old in your county, the average income in your county. We looked at all these factors. The region is what part of the country you live in. The vaccination month, what month you were vaccinated. Nothing significantly changed after that. You could see they only explained a very small percentage of the gap. So these factors are not contributing significantly once you account for the socioeconomic status of the individuals. The other row here is vaccinator characteristics. So this is things like the age and the gender of the vaccine provider. Remember, everybody here is vaccinated. And the percentage of patients of that provider that those who received the flu vaccine in the previous year. So when you add all these variables, essentially they make no difference. The size of the practice, the workload, we looked at all these factors and none of them really explained the gap. Now, the second more important variable here, other than socioeconomic characteristics in terms of explaining the gap, is whether your doctor had an access to the high-dose vaccine. And this is a bit counterintuitive. What you see here, that if your doctor or your vaccine provider in general haven't had a chance to use the high-dose vaccine, possibly because it wasn't available to them, or they are more likely to be egalitarian when they get the vaccine. If your doctor was a user of the high-dose vaccine in the previous seasons, they are less likely to give the vaccine to the minorities. And the last three rows at the bottom, that's what they show. That was very counterintuitive, but we think we understand what's going on there, and I'm happy to take questions about that. Now, the last two columns, I'll go through them quickly. We did the same analysis, but for people who were vaccinated in pharmacies, and generally the gaps were smaller for people who were vaccinated in pharmacies. So pharmacies were more egalitarian generally. And the gap narrowed significantly once we adjusted for the socioeconomic characteristics of the individual. So you could see the gap, whether in minority or a non-minority county, got very small, less than 7%, when we adjusted for education income of the individual. And once you adjust for the flu level, vaccination rates of the vaccinators, essentially how often they vaccinate their patients, the gap completely closed. So this is a very striking difference between the, what happens in physician offices compared to what happens in pharmacy. And one explanation that we have for that is that pharmacies probably, or people who practice in pharmacies, are more regulated in terms of what they prescribe. They follow maybe policies more closely, while physicians, they have a lot more room to make decision whether to give the high dose or the standard dose vaccine, and that's why we're seeing these differences in behavior between the two groups. So what to do? I mean, these are just ideas. I don't pretend to know, the healthcare system or the general situation in the U.S., but I'm just throwing out some ideas here for further discussion. I think it's important that we keep track of these inequities. I mean, this work was done as a research project, but I think it would be important to advocate for scoreboards and benchmarks and to share them transparently so people know what parts of the country, what regions, what counties, what providers have a better record in terms of giving high-dose vaccine to minorities. I still think that we don't really understand what's going on at the provider level, why physicians are more likely to, regardless of their age and workload, where they practice, are less likely than pharmacists to give high-dose vaccine for minorities. I think there is some space there for research that might involve, behavioral psychology and things like that to see what's going on in the mind of providers when they administer these vaccines. Engagement of the recipients of these vaccines, I think, is very important, that they're aware that this is going on. Healthcare reform. There have been we did some work looking at what helps providers to increase their general rate of vaccine administration. And we found that team-based training, when you involve the entire team in the clinic, for example, in training, that seems to work to increase the uptake of the or the administration of the vaccine to the clients of the clinic. Guidelines seem to help to some extent. Use of reminders, the evidence wasn't very clear. Incentives have been tried elsewhere, and they seem to improve, vaccine administration rates. So these are interventions that are specific to providers. And I think there is a lot of room there for research that looks into interventions that are tailored to reduce the gap in vaccine receipt between the different ethnicities, not just increase the overall rate. Then you have of course, the root causes of this problem, which is the social, economic, and cultural drivers. And I mean, I don't need to tell anyone in this webinar the importance of these factors and how changing them might not just change the opportunity for people to receive these preventative measures like vaccines and screening, etc., but their whole health outlook will significantly change based on, for example, their childhood experience or where they lived and their income levels, etc. Racism is the elephant in the room, of course, because although I don't really have any data, but it's really hard to look at this data and not imagine some form of structural or systemic discrimination that's going on here. And that's the end of my presentation. Thank you so much. And I'd love to thank the wonderful people that I worked with over the last 6 or 7 years on these different projects and continue to work with. Thank you.
Salah, thank you for presenting some of your work. There's a lot of conversation and questions going on in the chat and the Q&A. And I'm going to try to pose them for you. So one question is, the majority of vaccinated were not in the doctor's office. So you had the comparison of the pharmacy versus doctor's office. So were most vaccines delivered outside of the doctor's office in that?
No,
study?
no, that's just the percentage of people who received in that table. This table here doesn't really say anything about what percentage of people were vaccinated in either location. It just shows, like, out of the people who were vaccinated in a physician office, what was the size of the gap between the whites and minorities. But generally, I don't really have the exact figures, but my understanding is that it's way more likely, during that period at least, to get vaccinated in a physician office.
There's been a couple questions about the definition of minority. I wonder if you could review that again.
Right.
And
yeah.
I want to just also kind of bring up some specifics about it. One says, I'm a minority in US Indigenous. So is the data inclusion beyond the Black and Hispanic population?
Yes, it does. So I didn't get to this point, but I'm sure as a lot of people know here, the definition of race and ethnicity is a very contested concept. And to get out of this kind of dilemma and focus really on the core issue here, we just used the data that was collected by the insurers, Medicare or Optum, and both were based on a directive that was issued in the Clinton era that required healthcare providers to collect information on in 2 levels and 2 dimensions. One is their race, what's called race, and it was based on where your ancestry is from. Okay, so anyone who came from any part of Africa except Northern Africa was considered Black, regardless of what route they took, to get to the US, and how recent or was their migration to the US or enslavement. So clearly that's not ideal. Like, one of the problems, for example, is that North Africans like myself are considered white. And we know from COVID that North Africans have the same outcomes as minorities. They are not really whites when it comes to healthcare outcomes. So lumping them with whites, reduces the gap, the size of the gap, because it lowers the uptake levels for whites. Then the other dimension is ethnicity, which is whether someone is Hispanic or not. So we use these 2 variables essentially to classify people into Black, Hispanic, white, and other, which included the native indigenous populations in the various parts of the country.
Thank you
But
for.
it's not ideal. It's not
yeah.
ideal. And I am sure if we had a better, more refined definition of ethnicity, the gaps would have been even larger. Like to lump all the Asians together, for example, in one group just doesn't make sense at all to me. Like a Japanese and South, a Filipinese and an Afghani person, they have nothing in common, right? Other than they were part of, they're Asians. So if we had a better data, the gaps would have been much bigger.
I'm just going to note that there are folks talking about Native Americans and looking at IHS data, and also echoing your point about lumping in, Middle Eastern, African, North African, et cetera, problematic. Now, here's a question, and I think you hinted that you want to say more about this. When you say the physician was more or less egalitarian, are you speaking about the high-dose vaccine?
Yes. Yeah, and sorry if that wasn't clear, but all this table is, again, we use the same technique that we used in the previous analysis, because in this study, in the Medicare Advantage study, at that point, we were confident, based on our previous research, that just looking at the high dose was enough as a marker for inequities in the general uptake. And of course, it has the advantage that there is no issue with vaccine hesitancy or insurance. So that's why this analysis, this table, only includes people who are vaccinated. So everything that I'm saying here is about the receipt of the high dose vaccine. All these numbers are gaps in the receipt of the high dose vaccine. Everybody was vaccinated with the flu vaccine.
So they go on to say, in conclusion, physicians that were primed to use the high-dose vaccine were less likely to give the high-dose vaccine to minorities.
Yeah, I mean, it seems like once they had access to the vaccine and more experience with it, that they started kind of exercising more control over the process. Obviously, if they had no vaccine, no HD vaccine, there will be no gaps, right? Like remember, we're using the previous year here as a marker for what's happening in this year. So some doctors may have, not used the vaccine in the previous year, but received it that year. And so this is, for example, the row that says that the gap is only 10% when a doctor has not used the vaccine before. It talks about the use of the HD vaccine in this year for a doctor who has never used the vaccine before, a provider who has never used the vaccine before. It seems as people gain more confidence, more access, I don't know what. This is the part that's still not clear and requires a lot more research, why doctors start kind of discriminating at that point more often.
There is another question as to why only high dose was looked at as the alternative when, as of this last year, the ACIP has recommended a few for older individuals. That's
an excellent question. At the time when we did this study, the high dose was more than 95% of all these called differentiated vaccines. Since then, they have become more commonly used, but they're still dwarfed by the market share of the high dose vaccine. And actually in this paper, we also looked at all these differentiated vaccines, but it didn't really make a difference whether you look at the high dose or the differentiated, because the other vaccines, non-high dose differentiated vaccines, were just a very small percentage at the time.
So I guess I want you to say more about the providers and especially the physicians, and what you think, other than team-based training, something on your, so here's the, you said make a difference, guidelines, prompts, performance incentives, Can you talk a little bit more about what you would do?
Right. So, and I think you, Laura Lee, and I think Eamon, if he's in the audience, you have explored some of these factors, maybe in a different setting, right? Yeah, I think you were working with Costco, if I'm not mistaken. Or
We had done a project with Walmart.
Walmart, yes, Walmart. Sorry, I love Costco. So, yeah, so I think, and I'm not really sure about what was your experience with the use of the reminders in that setting, although that setting probably has a much better record,
Right.
given our data in terms of not discriminating.
Yeah, I think that the nudge they applied did have a small percentage but statistically significant increase in vaccinations,
Right.
which produced a lot more vaccinations. You know, a small percentage doesn't mean it wasn't a big amount.
Right.
You know, we do a lot of education and quality improvement of clinical teams. My sense is folks don't usually know their own data.
Right.
Not aware of gaps.
Yeah.
In fact, they are often shocked when they look at it, for example. I do think a team-based training on, you know, what's recommended, why it's important, and you know, how everyone on the team can contribute to a positive outcome with vaccination, that does make a difference. We routinely see in our QI practices a 10 to 20% increase in vaccinations.
Great.
But I would suggest that, you know, there's a lot of factors influencing what is used at the practice level when you're owned by a system. So some of the decision making is not at the physician level. Let me see if there's any other questions. You talk about racism, and you're talking about it at the individual provider level or kind of systemic bias in the whole system?
Right. Right. Yeah, both. Yes. So there's the interpersonal racism, which may have been operational in some of these cases, but I think there could be also structural racism, and there is evidence for that from the sequel to this study, where we look at different regions in more detail. And guess where the biggest problem is? Can anybody guess? In the US, like by looking at regions, if you look at big regions in the US, South, North, East, you know, Midwest.
Well, it looked like the South was doing better in the data.
No, the South is actually, well, the South is very interesting. What we found is that in the South, physicians were less likely to give the HD to anybody generally, but pharmacists were more likely to give it. So they were kind of compensating for the fact that the physicians were not giving the high dose vaccine. So I really don't understand why that's the case there, but generally they were in the lower kind of ranks of high dose vaccine use. So to me, that all points to decisions that are made at much higher level in terms of budget allocation, resource allocation, things like that, that would have impacted all physicians equally. But then, so that's the structural racism in the system itself. But then you have the interpersonal, which is just two people sitting across of each other and then kind of making decisions based on the ethnicity of each other.
There's another question, but I have a question too. And this may be unfair because you may not have studied it, but as you alluded to at the beginning of your comments, the last few years have been pretty challenging from a public health point of view. And I'm wondering what you have seen or what you conjecture the impact has been on flu vaccination and disparities? The COVID pandemic.
Oh, I know in Canada, it's way worse.
It made it worse.
It made it way worse. Like, for example, if you look at just even childhood vaccines, which we looked at in Canada, and things were way worse for everyone, but particularly for the minorities and the indigenous population. So I would guess that I haven't seen data for the US. We know that there are gaps. Minorities are less likely to get the COVID vaccine, but I haven't seen any data, to be honest, about the overall uptake of vaccines like influenza, not just COVID. So it seems like when the system is stressed, that, you know, equity kind of drops to the bottom of the list of priorities. And there are, again, structural reasons for that. Like in Canada, for example, in the province that I'm most familiar with, Manitoba, public health nurses used to give all the vaccines to the indigenous children. So when the COVID hit the country, all these nurses were redirected to COVID work, contact tracing, etc. And so nobody was vaccinating these kids. So vaccination rates dropped to 20-25% from 80-85% before the pandemic. So it's disastrous drop.
That's very interesting. We have another question about, have you looked at who orders the vaccine and what the drivers are for the selection?
I wish we had access to that data, but that's one of the other things that I thought that would be really important to look at. And that's something that maybe economists and behavioral economists could study, is what's the process, the decision-making process that results in the vaccine being sent to one community and not another community. Right? Is it related to the overall quality of healthcare in the region? That simply there are just better clinics, right, that are ahead of other clinics and more likely to respond quickly to changes in guidelines and new products and things like that. So I think it's really a very important topic and question that needs to be looked at. And because what's on this slide that I'm showing right now, if you're able to see it, of course, we know this was going on for centuries, right? It's not new that there are these problems. And our collective track record, whether it's in Canada or the US, hasn't been great in terms of trying to deal with these, as we call them, the root causes. I mean, that's the solution if we can, but it doesn't seem like we're able to do anything about it. So, short of that, I think, some of these kind of approaches where you focus on the providers, you focus on the decision makers, vaccine supply issues, things like that, I think might be like a quick way to fix the issue, at least when it comes to the flu vaccine uptake.
Well, that sounds like a great closing comment. And we are really at the end of our time. I thank you so much, Dr. Mahmud, for sharing your work. And I really thank everyone who's been in the audience. And you saw in the chat that there is a link to the recording of this, and we will definitely share the slides, which will be in the recording. I wish everyone a great weekend. Thank you.
Thank you so much. Nice weekend. Bye.